Hello everyone, happy evening, a very good evening. Am I audible and visible? All right, so I think I'm audible and visible, everyone. A happy evening, a very good evening. I hope and I believe all of you are doing well. So there's a slight change in the plan. This was supposed to be an in-app live session, but we are having YouTube live, right? So you should be thankful to the technical glitch that we are having YouTube live instead of the in-app live for everybody here. Okay. Uh, Yeah, Dr. VK, there are a lot of reasons that you would get to know only when you would be in our place. You would put yourself in our shoes and then you would get to know the reason. Right? The list is endless. अगर मैं वो बताने बैठ गई तो class नहीं हो पाएगा. Okay. Yes. And so here we are to discuss the dermatology PYQ. This is from the AIIMS, like the previous AIIMS papers. So that's why I particularly put it AIIMS because it's not even NEET. Just that to make sure that we do not miss out on the topics that have been asked in the previous years for the upcoming NEET exam. We are having this KBMD, which is Kaun Banega MD, which is fun way of saying that it is MCQ discussion. So of the previous year papers, we have done quite a few subjects. We have started with NEET PYQ KBMD in app. Right, so dermatology, we are doing it here today, YouTube live. This video will be uploaded for the in-app subscribers in app as well. Okay. Yeah, so give me a minute. Yeah, Sadik, a better way to estimate that or to understand that if you do only the short and the PYQs, the best way to understand that is you can actually give from any apps that you have, the other platforms as well, the previous NEET PG paper as a test and see that how much you are able to score out of that, right? So I think it should be a good bet basically. And one more thing that I would like to add is you can use the Medsynapse app plus complement it with RR and PYQs. So you'll be like, if we have to do rapid revision and PYQs, then why do we need to use the Medsynapse app? Remember, the Medsynapse app basically is there to bridge that gap, right? So where the concepts and mnemonics come together, right? There is no dearth of content anywhere, but the problem is in retaining and in being able to recall in the exam hall. So that is where I put a lot of efforts basically to help you retain and remember without revision. Whatever you are listening, you are watching for one time, you remember it forever. So that's what is all about Medsynapse and developing the MCQ solving skills through KBMD. Right. So like I say that the Medsynapse is like the cherry on the cake, and without that the cake is going to be incomplete. So your cake of preparation will not be complete without using that cherry. So make sure you do that. Okay. Yeah. So next one, and yeah. So without any further delay, let's start with the discussion for the today's session. This is your first question, guys. I've shared the PDF on the Telegram group already. Tell me, what do you think will be the answer to this? These particular questions that you see are favorite for AIIMS examiners. What do you think is the answer to this? 25-year-old girl presented with erythematous papules and the lesions were exacerbated on excessive sweating, sun exposure and emotional disturbance. What is the diagnosis? Very good. This is acne rosacea. Okay, this is acne rosacea. So in acne rosacea, the classical history would be like you see here, the lesions here on the convexities and which are precipitated by sun, emotional disturbance, sweating, plus sometimes there will also be history of the spicy food being there. And sometimes the question can also mention what is a very important keyword for acne rosacea, the presence of the prominent telangiectasias. Okay, the telangiectasias in the background is an important another finding there. How is it different from acne vulgaris? In acne vulgaris, the comedones are present, while in acne rosacea, there are no comedones. Okay, there are no comedones, remember that. So remember rosacea, like a rose, there is red appearance, there is red prominent vessels, telangiectasia, precipitated by sweating, spicy foods and all of those is acne rosacea. And remember acne rosacea in ENT, you have read the association with जब बहुत prominent होगा, it's there over the skin, big lesions over the skin. What is that? It is rhinophyma. Okay, that is rhinophyma. Remember rhinophyma, P for the potato nose. Okay, P for the potato nose. So remember rhinophyma is basically the associated with acne rosacea. Okay. Is this clear with everyone? Yes, there is sparing of the nasolabial folds. So this is how you differentiate from SLE. Okay. So that was the first question for this one. Now going to the next question. Again, we'll try to learn the mnemonic for this. What do you think is this one? Is this nevus of Ota, Ito, Becker's nevus, or is it the Mongolian spot? What has been shown here? Basically, there is this grayish lesion, discoloration in the eye. So remember that this is nevus of Ota. Absolutely right. This is nevus of Ota. O for ophthalmic. Okay, remember O for ophthalmic. Nevus of Ota, O is ophthalmic, that is eye wala rahega. And nevus of Ito, Ito ka hota hai TO. This is in the thoracic region, that's basically the scapula. Ito is on the scapula, the thoracic region. Where do you see the Becker's nevus? Again here scapular region. But along with the Becker's nevus, remember you would see the hair over the Becker's nevus. The hairy growth will be there over Becker's nevus. So remember Becker's will have black hair present over it. Okay. This is how you remember Becker's will have black hair present over it. Okay. That is how Becker's. Name itself tell you Becker's is on the back again, but with the black hair. On the back with the black hair is the Becker's nevus. Okay, that's what we need to remember. And Mongolian spot, it disappears, right? It is present in the infants, the neonates, the grayish discoloration. So remember that in hyperpigmentation, if I ask you that this nevus of Ota, is it a dermal melanocytosis or is this epidermal? कहाँ का pigmentation हो रहा है basically? Is it epidermal or is it dermal? Yes, this is an example of dermal melanocytosis. How do I know this is dermal? Dermal wala hyperpigmentation is grey color versus epidermal, which is more brown color. Okay, more dark brown. The dermal one is grey in color. So please remember this is example of dermal melanocytosis. So is Mongolian spot also, which is grey color. So epidermal versus dermal, dermal is grey, epidermal is brown, black. Okay. So remember ophthalmic wala, that's the trick there to remember. Ophthalmic, Ota is ophthalmic, Ito is thoracic, Becker's is on the back with the black hair. Okay, Becker's is on the back with the black hair. Okay. Alright. Let's go to the next question here. This has been asked in the previous AIIMS exams many times. What do you think is the diagnosis here? C. Absolutely right. This is lichen nitidis. Okay, this is lichen nitidis. Okay, lichen nitidis. So, the important point for lichen nitidis, remember these are small shiny papules. Okay, these are small shiny papules over the elbows, the shaft of the penis, over the face. It is lichen nitidis is small shiny papules commonly seen in childhood, in children. Okay, there is unknown etiology. This is commonly seen in children. So a child with this small shiny papules is lichen nitidus. The shaft of penis, elbows, face is the common area there. Okay. So remember that this is lichen nitidus, shiny papules, very important. On histopath, what do you see? Someone of you rightly mentioned. Very good, Niharika. It is the claw clutching ball appearance. Okay. So you would see a ball which represents the inflammation and the claw which represents the elongated rete ridges. So this is the ball in the claw or the clutch appearance, ball in clutch or ball in claw appearance. So because there is inflammation along with the long rete ridges, okay, along with the long rete ridges. So this gives the ball in claw or clutch appearance. Okay, so lichen nitidus, remember a child with shiny papules like this is lichen nitidus. Lichen scrofulosorum, like you have scrofuloderma TB wala, this is associated with TB. Okay, this is associated with TB. So the answer here basically is lichen nitidus. Remember shiny papules. Okay, it is shiny papules, right? Okay, going on to the next question here. What do you think? It's already given. So what kind of leprosy do you think is this one? What kind of leprosy do you think is this? Yes, absolutely right. Very good. You guys are awesome. This is BT type. Okay, borderline tuberculoid. Why is this BT? Because if you look at the lesion here, so basically it has these satellite lesions. Okay, the presence of these satellite lesions is characteristic of BT. Okay, the satellite is characteristic of BT. Okay, remember it is characteristic of BT. So borderline tuberculoid leprosy has satellite lesions. Very important. Remember satellite. Okay, satellite ending in T. So this is tuberculoid wala. This is BT. Okay, and what appearance are you seeing here? What appearance are you seeing here? The sloping edges, the inverted saucer appearance, which is seen in BL. Okay, which is seen in BB, BL wala. They show the inverted saucer appearance. Okay, they show the inverted saucer appearance. Is this clear with everyone? Remember that according to the recent recommendations, the WHO recommendations, whether it is paucibacillary or it is multibacillary, you give 3-drug regimen, which is given for 6 months and which is given for 12 months. Okay, 3-drug regimen, 6 months and 12 months, paucibacillary, multibacillary. For multibacillary, remember that even a single split skin smear, if it is positive, then it is multibacillary leprosy. Okay, even a single split skin smear, if it is positive, it is multibacillary leprosy. That's what you need to remember there. Okay, it has been tested in one of the recent NICT exams. I hope you remember for the lepra reactions, lepra type 1, lepra type 2. What is the mnemonic for lepra reaction? Type 1 is what? Hypersensitivity. Type 4. Type 2 is type 3 hypersensitivity. Remember the rule of 5. 1 plus 4 is 5, 2 plus 3 is 5. So type 1 is type 4, type 2 is type 3. When I say it is type 3, that means it is immune complex mediated, and that is why it is going to have systemic symptoms also, like fever वगैरह रहेगा, joint pains रहेगा, new lesions रहेंगे in type 2, which is ENL, erythema nodosum leprosa. ठीक है? And in both of them, the drug of choice is steroids. Thalidomide, remember thalidomide is used in though that is type 2. It is used in type 2 lepra reaction, not type 1. Okay, in ENL, there will be new lesions. In type 1 lepra reaction, it is the existing lesions which become red. Okay, so new lesions, fever, all these are features of type 2, the ENL. Is this clear with everyone? Right? So this is, remember, the satellite lesions is BT. Okay, satellite lesions is BT. All right, going to the next one. What do you think will be the answer to this one now? Yes, Vinay, absolutely right. You need to give NSAIDs, steroids, and continue the leprosy treatment. Do not stop the treatment. That is very, very important. So when you have this history, a question which is basically a patient from Bihar, UP का patient है, some skin lesions है, you should always think of, very good, the Kala Azar. Why is this not leprosy? Because remember, the normo-aesthetic rules out leprosy. A hypopigmented skin lesion with loss of sensation is leprosy. Remember, leprosy affects the nerves, and that is why the sensation is lost in leprosy. Here the sensation is normal, and that is why the leprosy is out. Okay, the three options are out. So this is post Kala Azar, that is visceral leishmaniasis के बाद dermal leishmaniasis. So this is dermal leishmaniasis. Classical question always asked is your LD wala bodies, where in the macrophages you see the amastigote form. Okay, you see the amastigote form in the macrophages. Very good, Chandan. NTRK39 is what you test for. What drug is the drug of choice for Kala Azar? It is liposomal amphotericin B. For dermal one, you can also use miltefosine. Okay, you can also use miltefosine. So amphotericin B, miltefosine, these are used for the treatment of leishmaniasis. Okay? Yes. So this history is very, very important. A patient from Bihar, this is very, very important. Okay? Right. So that was about this question. Going to the next one. Tell me, what do you think will be the answer to this one? Very good. So I think majority of you have answered it correctly. This is Bullas pemphigoid. Can you tell me why is this Bullas pemphigoid? Why this is not Pemphigus vulgaris? Why is this not Pemphigus vulgaris? Because remember that this is tense blisters and urticarial plaques is what is mentioned here. So very important, remember pemphigus ending in S is superficial, while Bullas pemphigoid, pemphigus and pemphigoid is deep. So understand that the superficial wala is going to be flaccid blisters and the deep wala is going to be tense blisters. That is one differentiating point. Second important, the mucosa involvement, the oral lesions are present in pemphigus, not in pemphigoid. Okay, that is very, very important. Plus the history of urticaria is important in Bullas pemphigoid. Okay, so remember this is Bullas pemphigoid, it is tense lesions is what is given. Dermatitis herpetiformis, remember the association with celiac sprue and the lesions over the elbows, knees, which are very, very pruritic. The papules, vesicles can come in dermatitis herpetiformis. Right? If I ask you the immunofluorescence appearance in Bullas pemphigoid, what do you see in the immunofluorescence? What deposition? Right, it is linear Ig deposition at the basement membrane, the dermoepidermal junction. Okay, the dermoepidermal junction. While in dermatitis herpetiformis, it is granular IgA deposits in the papillary dermis, granular IgA deposits. Linear IgA, as the term says, will have linear IgA deposit. Remember, this is linear IgG deposit. Okay, this is linear IgG deposit. And another important point to be remembered, Bullas pemphigoid versus dermatitis herpetiformis. Out of that, which one has neutrophils and which one has eosinophils? Which one has neutrophils in the light microscopy? किसमें neutrophils होंगे? Eosinophilic infiltration and neutrophilic infiltration. Yes. So remember that dermatitis, when I say dermatitis, it is itis, inflammation. So remember inflammation वाले में यहाँ पे होंगे neutrophils. Very good Lakshmi. This is going to have neutrophils and bullous pemphigoid will have eosinophils. Okay, bullous pemphigoid will have eosinophils. Okay, and your pemphigus vulgaris will have the fishnet pattern. Okay, it will have the fishnet pattern, very, very important. On light microscopy, it has row of tombstone appearance because you have the suprabasal split. Only the basal layer remains. Above that, basically there is the suprabasal split which is there. So there is going to be a blister here. So it gives a row of tombstone appearance on light microscopy. Okay, is this clear with everyone? So this is about your bullous pemphigoid. Pemphigus vulgaris, superficial. Pemphigoid is deep. So it is tense and this is flaccid. One of the recent NEET PG exam questions, which is the most superficial one? That is your pemphigus foliaceus, right? उसमें क्या होता है कि उसमें it is very, very superficial blister which is there, and rather than the blisters, the patient presents with crusting which is present, right? Scalp lesions, crusting is what is present there. Okay, that is the most superficial. Okay, that is the most superficial. Okay, this is most superficial and this has crusting which is present. Okay, this has crusting which is present, right? So that was about this question. Remember, tense is an important clue there for bullous pemphigoid. Going on to the next question, what do you think is the answer to this one? History of bulla involving more than 30% body surface area with erosion of the lips and other mucosa. What is the most probable underlying etiology here? Is it bacteria, virus, drugs or malignancy? Very good. This is drugs, because what are we talking about here? We are talking about 10. Toxic epidermal necrolysis. So remember, there is SJS, Steven Johnson, and you have the 10. In SJS, it is less than 10%. In 10, it is more than 30% body surface area which is involved, right? And these are most commonly associated with the drugs. Okay, these are more commonly associated with drugs. So SJS and 10. Do they involve the mucosa like you see here? Yes, they involve the mucosa. Versus your staphylococcal scalded skin syndrome, SSS. Staphylococcal scalded skin syndrome, as the term says, only involves the skin. It does not involve the mucosa. Okay, here the mucosa is also involved. So this is 10 most common in drugs. Remember that in fixed drug eruption, the person comes with history of the lesions at a fixed position and it heals with hyperpigmentation. Okay, and it heals with hyperpigmentation, right? So all these are the important points that you should remember here. SJS and 10 involve the mucosa. Staphylococcal scalded skin syndrome does not involve the mucosa. Okay, very, very important. Going to the next one, what do you think is the answer to this one? Yes. 7 months pregnant lady comes with the following lesions mainly on the trunk. Which of these drugs can be appropriately used in the treatment? What is this image showing basically? Very good. So the correct answer here is cyclosporin is what we can use. Retinoids, teratogenic, not to be used. Rest of the drugs not to be used in pregnancy. Tell me, what is the diagnosis here? Basically, this is pus filled. Okay, these are pus filled lesions. This is pustular psoriasis of pregnancy. What is it called as? Impetigo herpetiformis. Okay, that is Impetigo herpetiformis. Okay, so this is basically pustular psoriasis in pregnancy, impetigo herpetiformis. Otherwise, the history in pustular psoriasis is withdrawal of steroids. Withdrawal of steroids leads to pustular psoriasis. So remember, in pregnancy, you can give cyclosporin and otherwise you can also give steroids. Rest of the drugs are not to be given in pregnancy. So the answer here is cyclosporin. Can you tell me one side effect with cyclosporin which is very frequently asked in the exam? देखो गटेज सोरियासिस जनरली चाइल्ड वाला रहेगा, यूआरटीआई वाला रहेगा, फिर वो क्रॉप्स आएंगे on the trunk. This is pus fill, so this is pustular. Okay. What side effect is asked in the exam very frequently with cyclosporin? Yes. Remember the side effect, it shares the same side effect along with your phenytoin. Psychosis, do not get confused with cycloserine and cyclosporine. Psychosis, seizures, that is cycloserine. Yeah, it is basically your gum hyperplasia. Okay, remember this is frequently asked. Phenytoin, cyclosporin, they show gum hyperplasia, hyperplasia of gum. Okay, that is very important to be remembered. All right, going on to the next question. Tell me, what do you think is the answer to this one? Very good. This is lichen planus, because what do you see here in the image? This is a spotter image here. The lacy lesions in the mouth, this is Wickham's stria. Okay, this is Wickham's stria, which are seen in lichen planus. Okay, this is Wickham's stria. The important history of amalgamated third molar, this is one of the predisposing factor. This is lichen planus, PPPs, the 5 Ps. Plain, polygonal, purple, pruritic papules, that is lichen planus. Very important, remember in the nails, what is a very common finding? Nail pterygium is very common, right? What is common in the hair, in the scalp? It is one of the causes of scarring alopecia. Okay, it is one of the causes of scarring alopecia. Remember that point. And can you tell me the histopath findings with lichen planus? Very good, Priyanka. It is associated with hepatitis C. What else? What are the histopath findings? The lymphocytic infiltration in the dermis, right? Lymphocytic infiltration in the dermis is very, very important. Then there is Max-Joseph space. Okay, the Max-Joseph space, Sevate or colloid bodies, all this is important, Sevate or colloid bodies. Then there is basal cell degeneration. Okay, basal cell degeneration, all this is seen here. There is hyperkeratosis without parakeratosis. Okay, remember there is hyperkeratosis without parakeratosis. Parakeratosis, P for P, is seen in psoriasis. Okay, what do you mean by parakeratosis? P for P means there is persistent nuclei in the stratum corneum. This is not seen in lichen planus, it is seen in psoriasis. Right? Correct. There is sawtooth appearance. Again, there is sawtooth appearance which is seen here. The red ridges giving the sawtooth appearance. All these are important findings with lichen planus. Please do not forget ever lymphocytic infiltration. Okay, lymphocytic infiltration. Okay, right? So that was about lichen planus. Going on to the next question. What do you think is this one? This is basically segmental vitiligo. A lady comes with unilateral white skin lesions, and along with that there is leukotrichia. So this tells me the white hair along with the white skin lesion is vitiligo. In the nerve distribution, trigeminal nerve distribution, this is segmental vitiligo. Why this is not pubeldism? Because pubeldism basically has a white forelock as well. Okay, white forelock is present in pubeldism. Wartenberg syndrome, along with that, it has SNHL and other findings as well. Okay. So remember that vitiligo has leukotrichia. If you do the Woods lamp examination, vitiligo is white. So remember, it shows ivory white appearance on the Woods lamp. Okay, ivory white appearance. Yeah, segmental vitiligo means it is unilateral only. It is on one side along the distribution of the nerve, unilateral. Okay, it's not going to cross the midline. Absolutely right. Okay. So that was about this one. Going on to the next question. What do you think will be answer to this one? A patient presented with a vesicle on the shin and the zinc smear showed giant cells. A similar sort of question was asked in the FMGE exam as well. Right, vesicular lesions, zinc smear being described, giant cells is what is seen. This is varicella zoster or basically herpes zoster. Remember, for what lesions we basically use the zinc smear? For the fluid filled lesions, that is vesicles or bulla. Okay, so we rupture them, we take the base and we examine that. So along with, if it is herpes, you would see the giant cells. What do you see with HPV? Human papilloma virus क्या दिखाता है? What is the finding with HPV? Herpes shows giant cells, multinucleate giant cells. What does HPV shows? Yes. HPV. What does HPV show? Very good. HPV shows coilocytosis. Okay, it shows coilocytes. It shows coilocytes. So HPV shows coilocytes. Herpes shows giant cells. Okay, herpes shows multinucleated giant cells. Very, very important. Okay. So this has been asked in the exam. Zinc smear for herpes. You would see the multinucleate giant cell. Okay, you would see the multinucleate giant cell. Very, very important. Okay. All right. Going on to the next question, and I think this is the last one and an easy one. So a young male presents with following itchy lesions for 1 month. All of the following can cause this kind of lesion except. Very good. This is Aspergilus. So basically from the options, you know that they are talking about dermatophytosis, right? The skin fungal lesion. So Microsporum, Trichophyton, Epidermophyton, these cause the skin lesions. Aspergillus does not cause that. Very, very important point for Aspergillus you should never forget is Aspergillus is what angle branching? Remember, this is acute angle branching. Is it septate hyphae? Is it non-septate hyphae? When I write A, the line tells me that this is septate hyphae. Okay, so septate hyphae with acute angle branching. So if these are the hyphae, there is acute angle branching is Aspergillus. You should never forget this for Aspergillus. Okay, very, very important. Microsporum, Trichophyton, Epidermophyton. If you follow me on Instagram as well, recently I put this mnemonic reel ki microsporum. What is the shape of microsporum? Macroconidia. It is spindle shape. Right, and remember the other SS, it affects the skin and the scalp, that is the hair. It does not affect the nails. Okay, it does not affect the nails. Trichophyton affects all three, that is skin, hair, nails. It affects all three. Okay. Epidermophyton on the other hand affects epidermis, skin ka epidermis, and the N, it affects the nails. What does it not affect? It does not affect the hair. तो अगर कभी टीनिया कैपिटस का इमेज आया, रिमेंबर ट्राइकोफाइटॉन कर सकता है, माइक्रोस्पोरम कर सकता है, बट एपिडर्मोफाइटॉन नहीं करेगा. ओके, एपिडर्मोफाइटॉन नहीं करेगा. दैट्स व्हाट यू शुड रिमेंबर. एंड ऑल्सो रिमेंबर दैट in your inflammatory tinea capitis, a very important question which is frequently asked is chirion. Okay, so it is inflammatory tinea capitis. Common one is trichophyton, right? The mentagrophytes, verrucosum, mentagrophytes, and generally there is going to be history of a dog, a pet animal. History of dog is very, very important. The question will mention there is boggy swelling, history of dog. All this is chirion, trichophyton, mentagrophytes. Okay, right? Is this clear with everyone? And remember that one of the recent NEET PG exam question, mentagro, grows inside, goes and grows inside. So remember, it is hair perforation test positive. Okay, hair perforation test is positive. This was asked in one of the recent NEET PG exam also. So mentagrophyte is your hair perforation test positive. All these, whatever I've told you, are the important PYQs, right? So remember, mentagro shows the hair perforation positive. Okay, right? So yes, that was about the quick discussion of the some of the PYQs of the previous AIIMS exam. To be specific, like the AIIMS 2015 exam के dermatology के questions हैं. So all of these are important for your upcoming INICET and also for the NEET PG exam. I hope you have enjoyed it. We have done the rest of the subjects like orthopedics, physiology, microbiology. जो भी हमारा जो time table चल रहा है उसके हिसाब से we are doing the KBMD. The next KBMD we have is OBGY. A slight change in the plan is going to be. So the next KBMD will be in app, right? I hope the app will be back in place by then. So the next KBMD of AIIMS PYQs of the subject of OBGY, obstetrics, gynecology, that is going to be on 13th. Instead of tomorrow, that's going to be on 13th. We are going to do morning session then, right? So we are going to do the morning session on 13th itself, right? At 11:30 a.m. we will have the OBGY, 11 या 11:30 a.m. Okay, so that was about this one, guys. I hope you've enjoyed this. That's great, Niharika. Extra edge for INICET is we have an offline class in Hyderabad, and we will do it in app also. Either the offline recording or in live in app. Either of that we'll do in the app. Okay, so the app subscribers will get it in the app. And we have offline class also in Hyderabad on 30 April and 2nd May, 30 April to 2nd May. Apart from that, we have Sure Shot 5.0 offline class in Delhi for all the students, whether you are FMG, NEET PG, INICET. Basically, the Sure Shot topics, which are core topics and you cannot make a blunder in those. The Sure Shot 5.0 magic book will be entirely discussed there. So that is from 22nd to 25th April in Delhi. Okay, so whoever wants to register for that, I've shared the details on the Telegram group anyways. Fast 5 tha Ankit, but I think then we'll have to skip this for the Fast 5 because we've done a YouTube live, we have compensated today. So Fast Live will be after that. Okay, it will be on 15th then. We'll do it on 15th. No, Lakshmi, the PYQ classes are for in-app subscribers. The PYQ, the PYT PDF is free in the app. So if you want to see what topics have been asked in which year in INICET, NEET PG, that PDF is available for free in Medsynapse app. Okay, so thank you so much everyone. The app subscribers, I'll see you again on 13th, 11:30 a.m. for OBGY KBMD. Till then, goodbye, take care, and keep studying, keep revising, and keep winning. Thank you.